All right, let's jump right into cardiac electrophysiology. In this explainer, we're going to master how electrical impulses are generated and how they travel through the heart. This is the absolute core foundation you need to nail ECGs and understand arrhythmias on your exams. We're going to focus on exactly what's tested, using sharp contrasts and some great memory aids so you can spot these patterns instantly. Let's get to it. So here's our game plan. We'll start big picture by tracing the conduction highway. Then we'll dive into the heart's built-in backup systems, the pacemaker hierarchy. After that, we're zooming way down to the cellular level, comparing the two different engines, the fast and slow action potentials that make the heart tick. Then we'll see how the whole system is controlled, before we lock it all in with a super high-yield recap at the end.
Okay, first up, let's look at the macro view. The heart's electrical impulse doesn't just go anywhere. It follows a very specific, fixed pathway. And this is all for a reason. It's this beautifully coordinated sequence that makes sure the atria contract just a moment before the ventricles do.
So the whole journey kicks off at the SA node, which is the heart's natural pacemaker. From there, the signal just sweeps across the atria through these internodal pathways until it hits the AV node. Then, it takes a dive down the bundle of His, splits into the left and right bundle branches, and finally just ignites the ventricles in this big coordinated wave through the super-fast Purkinje fibers.
Now here's a detail that is absolutely critical, the AV node. Think of it like a gatekeeper. It deliberately holds on to that signal, pausing it for about 100 milliseconds. This isn't a glitch, it's by design. This little delay is what gives the atria just enough time to finish squeezing, we call that the atrial kick, and to top off the ventricles with blood right before they give that big, powerful contraction.
And this is a perfect example of a high-yield clinical tie-in. See, in most people, the AV node gets its blood supply from the right coronary artery, the RCA. So you can imagine, if a patient has a heart attack that blocks that specific artery, an inferior wall MI, the AV node can get starved of oxygen. And what's the result? Well, you get a disruption in that signal, which often shows up as an AV block or a dangerously slow heart rate, also known as bradycardia.
So what happens if the main pacemaker, the SA node, just stops working? Well, thankfully, the heart has some built-in backup systems. And that brings us to what we call the hierarchy of pacemakers and this idea of escape rhythms.
The rule here is really simple. The fastest pacemaker is always the boss. Normally, that's the SA node, chugging along at 60 to 100 beats per minute. If it fails, the AV node takes over, but at a slower pace of 40 to 60. We call that a junctional rhythm. Now, if that also fails, the Purkinje fibers kick in as a last-ditch effort, but they're super slow, only 20 to 40 beats per minute. This ventricular escape is really dangerous and often unstable, meaning it might not be enough to keep blood pressure up.
Now, let's talk about speed, because there's a huge difference in how fast the signal moves through different parts of the heart. The Purkinje fibers are like the Autobahn, conducting at a blazing fast 4 meters per second to make sure both ventricles squeeze at the same time. And the AV node? Well, like we said, it's the slowest point. It's that deliberate traffic jam, crawling along at just 0.05 meters per second.
And here is an awesome little memory anchor to help you keep these speeds straight. Just remember the phrase, park at Venture Avenue. Simple, right? Park is for Purkinje, the fastest. At for atria. Venture for ventricles, and avenue for the AV node, the slowest. It's a really easy way to lock in that order from fastest to slowest.
Okay, so we've covered the big picture conduction system. Now, let's zoom all the way down to the cellular level. We're going to dissect the electrical engine of the heart's workhorse cells, the contractile cells themselves.
These cells have what we call fast response action potentials. You'll find them in the atrial muscle, the ventricular muscle, and in that Purkinje system. And really, there are two defining features you need to know. They have an incredibly rapid spike of depolarization and then a very stable, flat resting potential in between beats. Let's walk through the phases. Phase 0 is this explosive upstroke, and it's all driven by a flood of sodium ions rushing in. Phase 1 is just a little dip as some potassium starts to leave. Now phase 2 is the really critical one. It's the plateau, where calcium coming in balances out potassium going out. This long plateau is so important because it prevents the heart from cramping up, what we call tetany. It ensures the heart has time to relax and refill. Then you get phase 3, the rapid drop as potassium rushes out, and finally phase 4, that nice, stable resting period.
Okay, now let's contrast those fast response cells with the really specialized cells that actually generate the heartbeat in the first place, the pacemaker cells. You'll see their electrical engine looks completely different.
These cells have slow response action potentials, and you'll only find them in the SA and AV nodes. Their key features are basically the exact opposite of the fast response cells. They have a much slower upstroke that's driven by calcium, and, most importantly, they have an unstable resting phase. This instability is the key. It's the source of the heart's automaticity, its amazing ability to beat all on its own.
The slow response potential is a lot simpler. It really only has 3 key phases. Phase 0 is the depolarization, and it's driven by calcium. Phase 3 is the repolarization, which is driven by potassium. But the real star of the show here is Phase 4. This is the pacemaker potential. It's this slow, steady, upward drift towards the firing threshold, and it's all powered by a unique channel called the funny current. The steepness of this upward slope is literally what determines your heart rate.
Okay, everyone, this slide right here, this is the money slide. This is the core, high-yield comparison you absolutely have to know. For phase 0, it's sodium in fast response cells, but it's calcium in slow response cells. For phase 4, it's stable and flat in muscle, but it's unstable and sloped in pacemaker cells. And for location, just think muscle and Purkinje for fast, and SA and AV nodes for slow. Burn this into your memory. And to help make that stick, here's another fantastic memory anchor. Think of it this way. Fast response is like fast food, which is high in sodium. And slow response is like slow dairy, which is rich in calcium. It's a simple little association, but trust me, it will save you points on an exam.
So we've got this incredible intrinsic pacemaker system. But how does your body tell it to speed up during exercise or slow down when you're resting? Let's zoom back out and see how the autonomic nervous system acts as the master controller for all of this.
It really all comes down to messing with that phase 4 slope in the pacemaker cells. The sympathetic system, that's your fight or flight response, it acts like an accelerator on a car. It makes that phase 4 slope steeper, so the cell hits its firing threshold way faster, and that increases your heart rate. The parasympathetic system, that's your rest and digest, is the brake. It flattens the slope and even hyperpolarizes the cell, making it take longer to fire, which slows the heart rate down.
This brings us to a clinically vital drug, adenosine. What adenosine does is it strongly mimics that parasympathetic brake, but specifically on the AV node. It throws open potassium channels, causing this profound hyperpolarization. This creates a temporary, complete AV block, which is incredibly useful for slamming the brakes on certain types of fast heart rhythms that rely on the AV node to keep going.
All right, that was a lot, so let's consolidate everything we've just covered into a final rapid-fire review. These are the absolute must-know, exam-ready facts that you need to take away from this.
Let's lock these in. First, pacemaker rates go from fastest to slowest. SA node, then AV, then Purkinje. Second, the ion for phase 0 is sodium in muscle, but calcium in pacemaker cells. Third, phase 4 is stable in muscle, but unstable and drifting up in pacemakers. Fourth, the AV node is your slowest conductor and it's usually supplied by the RCA. Fifth, that long phase 2 plateau is what prevents tetany, allowing the heart to fill. And finally, a key drug fact. Ivermectin works by specifically blocking that phase 4 funny current to slow the heart rate.
And we'll end with a question to get you thinking and to tie all this together. Based on what you now know about the ions that create the resting potential, how would a change in potassium levels outside the cell affect phase 4 in a contractile cell? And, taking it a step further, what kind of dangerous arrhythmia might that change make more likely? Think it through. It's a great way to synthesize these concepts. Thanks for tuning in.